Today we're going to provide a lecture on how to perform the radical abdominal hysterectomy. Our objectives are as follows. Number one, to describe the relevant surgical pelvic anatomy. And number two, to describe the steps and substeps involved in performing a type 3 radical abdominal hysterectomy. The first objective, describing relevant pelvic anatomy, will give a brief view of the blood supply to the human female pelvis, the pelvic retroperitoneal spaces, the pelvic ligaments, and pelvic viscera. The pelvic surgeon should have a thorough understanding of the anatomy of the human female pelvis, particularly the multiple branches of the anterior division, excuse me, of the internal iliac artery, many of which he or she will encounter during the performance of the type 3 radical abdominal hysterectomy. Here's a surgical diagram of the arterial blood supply to the human female pelvis, and it should be intensively studied by the surgeon. We will now talk about the pelvic retroperitoneum and pelvic retroperitoneal spaces. Critical to performing the radical abdominal hysterectomy is a clear understanding of the pelvic retroperitoneum, the structures that make it up, their anatomy, and how to access them. What you see on the screen now is a superior view with the pelvic peritoneum intact. The surfaces of the bladder, uterus, round ligaments, fallopian tubes, uterosacral ligaments, ovarian ligaments, infundibular pelvic ligament, and the rectum are all covered by parietal peritoneum, which is a very thin and transparent layer of tissue. This slide gives a close-up sagittal view of demonstrating how the parietal pelvic peritoneum, which is colored in blue, envelopes the surface of the bladder, the surfaces of the bladder, uterus, and rectum, forming the anterior and posterior cul-de-sacs. Now, Mikhail, can you see my arrow? Can you see the arrow?
Yes, I can, Prof.
You
yes.
Can? Okay,
yes.
Good. All right. This slide represents view with the uterus peritoneum now removed. One can clearly see the retroperitoneal structures such as the ureters, the infundibular pelvic ligaments, which consist of the ovarian veins, arteries, and lymphatics, the paravesical space, the pararectal space, the rectovaginal space, which is the space between the anterior rectum and the posterior vagina, the vesicovaginal space, which is the space between the bladder and the cervix and, between the bladder and the cervix and vagina, and the uterosacral ligaments. The radical hysterectomy primarily consists of surgery to remove the uterus, cervix, parametral tissues, and part of the upper vagina. The fallopian tubes are usually removed because of their risk of developing fallopian tube cancer post-operatively. And depending on the age of the patient and how the structures appear, the ovaries may be preserved. The uterus and cervix are held in place by several ligaments. Each of the ligaments must be transected in order to remove the uterus and cervix. The essence of the radical hysterectomy consists of opening up and visualizing the retroperitoneal spaces. And again, if you look at the diagram on the right, you will see that in the yellow areas, the paravesical spaces, the vesicovaginal space, in the pink, the pararectal spaces, and the rectovaginal space. Also the vesicovaginal space. The essence of the radical hysterectomy consists of opening up these opening up and visualizing these retroperitoneal spaces, followed by identification and transection or division of the pelvic ligaments, while avoiding damage to surrounding vital structures such as the bladder, ureters, and rectum. Now, if we look at the diagram on the left, you will see that the ligaments and retroperitoneal spaces can be seen. The points where the ligaments are transected or divided are represented by the following colored lines. The uterosacral ligaments, and where they are transected during the radical abdominal hysterectomy, are represented by the green line. The cardinal ligaments, and where they are transected or divided during the surgical procedure, are represented by the blue line, and the vesico-uterine or pubovesical ligaments, and where they are transected or divided during the procedure, are represented by the red line. So red line is the transection of the pubovesical or vesico-uterine ligament. Blue line is representative of the point where we transect or divide the cardinal ligament, and the green line represents the point where we transect the uterosacral ligaments. This is done on both sides bilaterally and allows us to then remove the remaining attachment of the uterus, which is the distal vagina. And that is in essence what the radical abdominal hysterectomy is all about. Now, we'll walk through the steps and substeps of the radical hysterectomy. There are 5 major steps to the radical abdominal hysterectomy. 1, exposure of the lateral pelvic retroperitoneal spaces, something we've already talked about. Mobilization of the ureters to their points of entry into the bladder. Division of the uterosacral ligaments, division of the cardinal ligaments, and division or transection of the pararectal, which is the tissue lateral to the vagina, and the vagina itself. Now, each of these steps has substeps, and we'll talk about the most critical substeps. We said the first major step was to expose the lateral pelvic retroperitoneal spaces. The substep is opening the paravesical and pararectal spaces. The second major step is mobilizing the ureter to its point of entry into the bladder. That has several substeps. 1, identification, ligation, and division of the uterine artery at its point of origin from the internal iliac artery. 2, separation of the ureter from its attachments to the medial leaf of the broad ligament and cardinal ligament. 3, mobilization of the bladder off of the anterior surface of the uterus and vagina. 4, division of the vesico-uterine or pubovesical ligament, which is sometimes referred to as unroofing the ureter because they make up the roof of the ureter. And number 5, dissection of the ureter from the connective tissue attachments down to its point of entry into the bladder. The third major step is division of the uterosacral ligament, and its substeps are mobilization of the anterior surface of the rectum off of the posterior surface of the vagina, and then clamping and dividing the uterosacral ligament at its midpoint between the sacrum and the back of the vagina and uterus. The fourth and fifth major steps are division of the cardinal ligament and division of the pararectal and vagina. So now we'll go through these steps and major steps. 1, exposing the lateral pelvic retroperitoneal spaces. The round and broad ligaments are divided near the pelvic side wall. Incision is extended anteriorly, parallel to the obliterated umbilical artery, and posteriorly over the psoas muscle, parallel to the infundibulous pelvic ligament. So I'll show you what that means. Here we have the cut ends of the round ligament. When this ligament is intact, it stretches from the side of the uterus to the pelvic sidewall. And behind it is a broad band of tissue that covers over this area that is called the broad ligament. Once this round ligament is divided, the broad ligament is then further divided and then has a lateral and medial aspect. The incision into the broad ligament is carried anteriorly towards the obliterated umbilical artery and posteriorly towards the psoas muscle, opening up this area, which is the pelvic retroperitoneal space. The paravesical and pararectal spaces are usually opened bluntly using the surgeon's fingertips. Now, the paravesical space gets its name because it is lateral to the bladder. The pararectal space gets its name because it is lateral. Rectum is the bladder. Paravesical space, pararectal space. Again, the paravesical space is developed by retracting the obliterated umbilical artery medially and bluntly dissecting downward towards the pelvic sidewall anterior to the uterine artery. So we use a clamp to grasp the obliterated umbilical artery. We pull it medially and we dissect down into the pelvis, headed towards the pelvic sidewall, anterior to the uterine artery. Now, the borders of the paravesical space are medially the obliterated umbilical artery, laterally the fascia of the obturator internus muscle, anteriorly the symphysis pubis, and posteriorly the cardinal ligament and uterine artery. Here they are listed as I just listed them. Now, the pararectal space. The pararectal space is developed again using blunt dissection between the ureter and the internal iliac or hypogastric artery, posterior to the uterine artery. The dissection is parallel to the sacral curve. Again, the pararectal space is developed using blunt dissection between the ureter and the internal iliac artery, posterior to the uterine artery and cardinal ligament, and anterior to the sacrum. The borders of the pararectal space are laterally, the internal iliac artery, medially, the ureter and rectum, posteriorly, the sacrum, and anteriorly, the uterine artery and cardinal ligament. And here's the pararectal space. These are the borders, as they were just named. Now, once the paravesical and pararectal spaces are open, these are the retroperitoneal spaces, because they're underneath the peritoneum. The surgeon is then able to more clearly visualize the following vital structures: the external and internal iliac arteries, the uterine artery as it branches off of the internal iliac artery, the cardinal ligament, which is a ligament separating the paravesical and pararectal space, the obliterated umbilical artery, and the pelvic ureter as it courses underneath the uterine artery. These are structures that must be identified in the process of performing the radical abdominal hysterectomy. It is particularly important to understand the anatomic course of the pelvic ureter, here it is, and its relationship to the uterine artery. That is, it courses underneath the uterine artery, and the vaginal artery, which is a branch of the uterine artery that that drops off and supplies the vagina prior to the point where the uterine artery crosses over the ureter. It's particularly important to understand this relationship, because if not, during the surgical procedure, the ureter can be damaged. Once all of these structures are identified, the uterine artery, again, here it is, branching off of the internal iliac artery towards the uterus. It is a major blood supply to the uterus. The uterine artery is identified as it branches off of the internal iliac artery. Here it is again. It is doubly clamped divided, and suture ligated or cauterized. Then the medial stump of the uterine artery, the medial part that has been tied off, is pulled over the ureter, up and over the ureter, exposing this portion of the ureter, so it can be so the ureter can then be moved laterally. Here we see how the ureter courses underneath what is called the ureteral tunnel, part of which is made up of the vesico-uterine or pubo-vesical ligament. But the uterine artery has been removed. Here's the uterine artery. Been cut, has been ligated, cut and ligated, and here's the uterine artery coursing towards the bladder. And this uterine artery, medial stump, is pulled up over the ureter, so that this tissue, the remaining portion of the ureteral tunnel, can be transected. And we'll see how that happens in a minute. Now, we then get to the point where we are now going to continue to mobilize the ureter to its point of entry into the bladder by unroofing the ureter. So after the stump, the medial stump of the cut uterine artery has been pulled up and over the ureter, the remaining connective tissues that are covering over the top of the ureter are further divided. Then the bladder is mobilized or pushed down off of the anterior surface of the uterus. The ureter is then separated from its attachments to the broad ligament, here's the broad ligament, and cardinal ligament. So the ureter is separated from is then further making up the roof of the ureter. I'll go back and show that to you again. This is the tissue that makes up the roof of the ureter. This is that same bundle of tissue. So the ureter is further unroofed by placing a right angle clamp, that is a metal clamp that is in the shape of a right angle. The ureter is further unroofed by placing a right angle clamp, 90 degrees, along the superior medial border or surface of the ureter. And underneath this vesical uterine ligament, getting into the correct plane is crucial to avoid damaging the ureter. So we are now placing a clamp on the top of the ureter, but underneath the roof. So the ureter is going through a tunnel, and we are undermining this tunnel because it's going to be clamped and cut, further exposing the ureter as it courses towards the bladder. Now, the ureter can also be unroofed using scissors instead of a right angle clamp. It's the surgeon's choice. But in any case, once this tunnel is isolated, undermined, and identified, it is doubly clamped. A clamp is placed here, and a clamp is placed medially, and a clamp is placed laterally. It is doubly clamped, then divided with scissors and sutured. Here it is being doubly clamped and sutured. Doubly clamped. This is the vesical uterine. This is the ureteral tunnel that's been clamped, cut, and now it is being sutured. And when this is pulled medially, the ureter, as it courses into the bladder, will be exposed. And all of this tissue will be removed with the specimen and is considered to be parametrial tissue. We then turn our attention to the posterior aspect of the surgical procedure, which is division of the uterosacral ligaments. The first step towards identifying and dividing the uterosacral ligaments is mobilizing the anterior rectum off of the posterior vagina. And the first step is to incise the posterior cul-de-sac peritoneum. This peritoneum that reflects off of the back of the uterus onto the anterior wall of the rectum. This is usually done with scissors, sharply. Once this space is open between the rectum and the vagina, posterior vagina, which is called the rectovaginal space, the posterior vagina is bluntly separated from the pararectal fascia using a sponge tip or either the surgeon's fingers. When this occurs, the uterosacral ligaments can then be identified, and they are isolated, clamped, and divided close to the rectum. Again, this is one of the ligaments that has to be removed in order to remove the uterus, cervix, and vagina, the uterosacral ligaments. We just finished dividing the vesical uterine ligament. Now that's anterior. Now we're posterior, removing, transecting, or dividing the uterosacral ligament. After the uterosacral ligaments are divided, we then remove the remaining attachments between the posterior vagina and the anterior rectum, which we call the rectal pillars. And one has to be very careful doing this, or he or she can inadvertently puncture the anterior rectum. Now, so we've divided the vesical uterine ligaments anteriorly, the uterosacral ligaments posteriorly. Now we turn to the cardinal ligament, which is the lateral ligamentous attachment of the uterus and cervix and vagina. The cardinal ligament is divided in one or two bites, preserving the inferior portion through which the autonomic nerves pass that innervate the bladder. And this will prevent us from having what is called a neurogenic bladder, with the patient being unable to urinate, sometimes up to several months. But these nerves course through the cardinal ligament in the lower 1/3. So when we make our transection through this tissue, we make sure we only remove the upper 2/3. Now, following the division of all of the pelvic ligaments, the uterosacral posteriorly, the cardinal laterally, and the vesical uterine or pubocervical anteriorly, all of the pelvic retroperitoneal spaces are united. That means the rectovaginal space is united with the pararectal space, which is united with the paravesical space, which is united with the vesicovaginal space. The last bite of the lateral tissue, or what we call the parametrium, the tissue lateral to the uterus, is across what is called the paracolpos, which is the tissue that is lateral to the vagina. And we take this division just up to the lateral wall of the edge of the vagina, just the lateral edge of the vagina, but we don't clamp the vagina at this point. The last step is then to clamp across the vagina 2 to 3 centimeters distal to the palpable limit of the anterior cervix, so that we are able to remove 2 to 3 centimeters of upper vagina and get a clear margin, a clear tumor-free margin. Once the vagina is clamped on both sides, it is then cut and the specimen is removed. Thank you very much.